Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to a presentation on mastering chest X-ray readings. It's a presentation that will empower you with simple tools and rules to smartly read and confidently interpret chest X-ray abnormalities. For those who do not know me, I'm a primarily consulting internist with interest in pulmonary medicine. And I've actually been involved in competency-based medical education and training for more than 20 years. Now, for this presentation, this is actually the roadmap that we're going to go through, right? Now, if you master these 5 steps, right, or you're aware of these 5 steps, then you will confidently read and interpret chest X-rays. Now, the first step is actually about knowing the history, and that includes an old chest X-ray. Now, never attempt to read a chest X-ray without having some clinical data about the patient, and having a look at an older chest X-ray if it's at all available. The second step is you really need to know and master the anatomy of a chest X-ray. The third step is about assessing the chest X-ray technical adequacy. The fourth step is knowing the patterns. Unfortunately, many diseases have similar patterns, and therefore you really should be medically knowledgeable to be able to identify these patterns and differentiate between them. A very important and critical step is knowledge about the rules. There are numerous rules which govern what a normal chest X-ray should look like, right? And you should be quite aware, right, of these rules. If you are really great in all these above 5 steps, then you'd really be a master in chest X-ray reading and interpretation. Now, the normal anatomy, you really need to know what the cardiac anatomy looks like in a chest X-ray, the lung anatomy, the bones, right? For example, this is a normal chest X-ray, right? Now, it's important that you're aware of the anatomical, structures. This is the trachea, right? The trachea bifurcates into a right main bronchus and a left main bronchus, and this is the carina. Now, an important rule is that this carina should be less than 90 degrees. Trachea is usually central, so this is another rule. It's usually central, but might be deviated slightly to the right. Now, this is the right pulmonary artery. This is the left pulmonary artery. This is the aortic knuckle, right? The aortic knuckle is on the left side, right? The space between the aortic knuckle and the left pulmonary artery is called the aortopulmonary window. This is the left heart border. The left heart border is made by the left ventricle. This line is the descending aorta. On the right side here, this is the right heart border, right? And the right heart border is made by the right atrium. Now, this is the hemidiaphragm. That's the right hemidiaphragm, and on the left here is the left hemidiaphragm. Now, you can see the right hemidiaphragm. You can actually go through it, from end to end. It's very clear. This is called the silhouette sign, and it's the interface between the air-filled or gas-filled lungs and the solid organs. And this line is also a silhouette sign. It's crisp clear. You can trace it from top to bottom. Now, this is the costophrenic angle, and the rule for that is that it should be sharp and deep, right? Sharp and deep. Now, the right hemidiaphragm is actually higher than the left hemidiaphragm. The left hilum, on the other hand, is higher than the right hilum, right? So these are important rules that you should really be aware of. Now, this is behind here is the gastric air bubble, and it's on the left side, and it sits immediately below the left hemidiaphragm. There might be a colonic air bubble here. Now, these are the ribs. Now, this is the first rib, this is the posterior aspect of the rib, and this is the anterior aspect of the rib. The posterior aspect is usually horizontal, while the anterior aspect is usually oblique. Now, if you look on the lateral film, right, you can see that this is the aortic arch, right, and this is again the trachea, the posterior heart border and the anterior heart border, right. The anterior border is primarily made by the right ventricle, and the posterior heart border is primarily made by the left ventricle and atrium. This is the posterior costophrenic angle. Again, it is black, sharp, and deep, right? And this is the left hemidiaphragm, and this is the right hemidiaphragm. Now, again, these are the ribs, the aortic knuckle, aortopulmonary window, the left pulmonary artery, the left heart border, the descending aorta, the carina, the right pulmonary artery, the right heart border, the right hemidiaphragm, the costophrenic angle. This is the breast shadow, the gastric air bubble, and the colonic air bubble. And you should be able to see the ninth or tenth rib posteriorly, on a well, a good X-ray with good inspiratory effort. Unless a patient obviously has a restrictive lung disease, when you can probably not see the ninth rib or tenth rib posterior aspect. Now, on a lateral film, you can see the right ventricle is anterior, the left ventricle and left atrium actually make the posterior part of the heart on the lateral film, and this is the aortic arch. Now, this is the retrosternal space on the right, on the front here, and the retrocardiac space at the back of the heart. Right? Important rules is that as you go down, it becomes darker, it's more black. Right? If you're going down and it's actually whiter, right, then there is a pathology on this area. And again, you can see the deep costophrenic angle, the posterior costophrenic angle is very clear here. Right? So, right costophrenic angle, you can see the right main bronchus here on this X-ray. You can see the carina, the left main bronchus, the trachea, the left hemidiaphragm, and again the right hemidiaphragm is higher than the left hemidiaphragm. On the other hand, the left hilum is usually higher than the right hilum. It should be concave outwards. The hylae should be concave outwards, and you can see that they are concave outwards. This is the trachea, and this is the the tracheal edge on the right side here. And this should be less than 3 millimeters in width. Right? It's important to recognize that the right side, the right lung, has 3 lobes: right upper, middle, and lower, and the middle lobe abuts the right heart border. So it's actually sitting by the right heart border, which is primarily made by the right atrium. Right? On the left side, there are 2 lobes: left upper and left lower. The lingula is part of the left upper lobe, and it sits by the heart border, so it's actually abuts the left ventricle. Okay, there are other important elements. Obviously, are the pulmonary vessels, the diaphragms, and the right hemidiaphragm should always be higher than the left. Now let's go through some interesting pictures, which will just give you a feel of how the lung lobes markings, on a chest X-ray will look like. The lobes of the lungs. Now you can see it as the right upper lobe, and it goes all the way from front to back. Okay, and this is the transverse fissure, right, or sometimes called the minor fissure. So this is the right upper lobe, and it's actually, and usually the transverse fissure goes from the hilum to the side of the chest. Right, that's the right middle lobe, and you can see the right middle lobe is actually anterior, right, and it touches the right heart border. It touches the right heart border, and it had a triangular appearance if you look at it, on a lateral film. The right lower lobe border, the right lower lobe, is actually a posterior structure, right, and you can see it sits straight on the hemidiaphragm, the right hemidiaphragm. So if you have any pathology there, it will cause the silhouette sign to disappear. right? And you can see that the right lower lobe actually goes all the way up to the lung apex posteriorly. So it's a posterior structure, again a triangular structure. Right? And you can see the right upper lobe is actually differentiated, or the border between it and the middle lobe is actually the minor fissure. The border between the right and the two lobes, right and middle, and the posterior is actually the major fissure, or sometimes called the oblique fissure. Now let's go to the left side. Now the left upper lobe, you can see it's anterior, occupying almost all of the front of the left lung, right? And it sits, this is the lingular process of the left upper lobe, right? And you can see the lingular component of the left upper lobe, and you can see it sits by the left heart border, right? And again, the left upper lobe actually occupies most of the anterior aspect, almost all of the anterior aspect of the left lung, on an X-ray, right? If you look at the lower lobe, right, the left lower lobe, actually it sits posteriorly. Again, you can see it's very similar to the right lower lobe, right, occupying mostly posterior aspect of the lung, with an apex with its peak or a tip moving all the way up almost to the apex of the right of the left lung, right. And a major fissure or oblique fissure, makes up the border between the left upper lobe and the left lower lobe, right. Right, so the right upper and right middle lobes are separated by the horizontal or minor fissure, sometimes called the transverse fissure. Right, the right lower lobe is separated from the middle and upper lobes by the oblique or major fissure, and the left upper lobe is separated from the left lower lobe by the oblique fissure on the left side. Okay, now these are the retrosternal spaces and retrocardiac spaces, and as I said, this should be darker and a sharp cosophrenic angle at the bottom, right? And this is the left diaphragm, this is the right diaphragm. Okay. Now, important to recognize that the X-ray, that the mediastinum is usually divided into two parts, superior and inferior, and the inferior mediastinum has three components: anterior, middle, and posterior. And the anterior mediastinum is anterior to the pericardium, right? That's the anterior mediastinum. The middle mediastinum is actually between the anterior and posterior mediastinum, and this includes the heart, right, and major vessels in this area. And then the posterior mediastinum is posterior to pericardial surface. Now, this is a way of actually identifying the anatomical location of abnormalities when you look at an X-ray. You really need to know about the bones, the ribs, clavicle, spinous processes, and transverse spine. And in a good X-ray, you can just just about see the vertebrae. If you see them very clearly, then the film is really very over penetrating. But they should be just about seen on a well exposed X-ray. This is the clavicle, the left one and the right. You can see there is a bit of lung always above the clavicles, and this is the spinous processes. You can just see them behind the trachea and the gastric air bubble. Right? Right, now the ribs, as I said, this is the anterior part and posterior part of the ribs, and a patient with a good inspiratory effort, you will probably see the posterior aspect of the 10th, 9th or 10th ribs. Okay, so this is the posterior aspect. You could just see them, and if you above the diaphragm. If you can see them, then there's a good inspiratory effort. But be aware that sometimes you cannot see them, not because the patient did not take a good inspiratory effort, but simply because they have restrictive lung disease, like musculoskeletal disease or pulmonary fibrosis, and therefore you cannot see them, right? And this is the gastric air bubble with the fluid level there in the stomach, right? Be aware if you see this behind the heart, then you have hiatus hernia. Right? It's important to be aware of there's something called the azygous lobes and fissures, and this is actually a rudimentary embryonic origin, old vessels there, and you can see just now how do we systematic approach to interpreting chest X-ray, right? Now you really need to go through these steps in a very structured way. The history, including an old chest X-ray, be aware of that, and then look at the correct, make sure that you're looking at the correct patient's name, date of birth, and medical record number, the date and time the X-ray was taken. The projection was it's an AP or PA film. An anterior posterior film makes it difficult to interpret the cardiothoracic ratio, right? And look at the position, erect or supine. Supine means that supine film means that the patient is ill. Make sure that you can see the 9 to 10 posterior ribs. That's a good inspiratory effort. And make sure that the penetration, thoracic, intervertebral discs just visible, and make sure that there's no major rotation, and you can assess the rotation by assessing that the medial clavicular heads are equidistant to the spinous processes. Right? Look at the lungs, pleural spaces, cardiomediastinal contours, bones, soft tissues, and abdomen. These are the areas you have to evaluate. Okay. Don't forget to focus on the apices, retrocardiac areas, left and right, and below the diaphragm, because these are the areas where so frequently people miss. Okay, so focus on these areas when reading chest X-ray. Right? In general, when you look at lung abnormalities, they are either it's more white than it should be or more black than it should be. Okay, but then if it's more white or more black in the lung X-ray or the rib, for example, okay, then you really need to know the pattern so that to identify the pathology or have an idea about the pathology. So there are the usual patterns are airspace opacity, interstitial opacity, nodules and masses, lymphadenopathy, cysts and cavities, changes in lung volumes, increase or decrease, and pleural diseases, right? So these are the patterns of diseases. Now, airspace opacity, the pathognomonic sign of airspace opacity, which means that there is fluid inside the alveoli, be it pus, blood, water, whatever, is air bronchogram. If interstitial opacity means you're dealing with lines, okay, so you can see lines without air bronchograms, and you say this is interstitial opacity. And then nodules and masses. If it's a nodule, it's less than 3 centimeter. If it's bigger than 3 centimeter, you call it a mass. Okay, and there are micronodules, for example, 2 millimeter, for example, very small nodules or micronodules. For example, you see it in biliary TB. Right? You really need to assess for patterns like the cardiomediastinal contour abnormalities, the bones and soft tissue abnormalities, and you look at the below diaphragm, right, to assess for any abdominal pathology. Okay. Now let's go through a fascinating part of the talk. Now this is about actually highlighting the rules, right? And if you know the rules, you're more likely to identify the pathology fast. Okay, but if you don't know the rules, you will just look at an X-ray and you're not sure what's going on. So the important thing is actually to be aware of these technical rules. Now the opacity of the lungs should be symmetric unless the patient is rotated. So the blackness or the whiteness of the lungs should be the same on the left and the right. Right? A young healthy person should take a good breath deep enough so that you can see the 10th rib posteriorly, okay, or the 6th rib anteriorly. Now, that might not happen not because of pathology, not because the patient is not taking a deep breath in, but because of pathology, as I mentioned, because of restrictive lung disease, fibrosis, musculoskeletal disease, and so forth. When you look at an X-ray, the right lung is bigger than the left. So, because it has 3 lobes, the other one has 2 lobes. Okay. Now let's look here. Now these are 3 films, right? And one is inclined to say this is abnormal, this is okay, maybe this is okay. As a matter of fact, these are all for the same patient at the same time. So it's just a difference in penetration. Okay, so the difference in penetration is giving you a more white or a more black film. So be aware of these technical differences that will change the way the X-ray will look like, whether it's like black or white. Okay. Now again, in this patient, you would say, right, it's the same patient, right? In here, you probably say, oh, maybe the heart is a bit bigger than here, and maybe there is a shadow there. But actually, you see, it's just a rotated view. You can see that the clavicles are not equidistant from the spinous processes in the middle there, right? And therefore, the rotation is giving you, you're likely to misinterpret. So be aware that to look at the rotation, right? The blackness or the whiteness, depending on the penetration, right? And the, changing in the way you look at X-ray, in the interpretation of the X-ray, because simply you have not actually paid attention, right, at whether they are rotated or not rotated. Right? Now another one, yeah. Now you can see that, well, this patient actually has some basal infiltrate, but as a matter of fact, they're the same patient. The difference is simple, right? Is actually that the poor inspiratory effort, you could not see the 10 strip, 9th or 10th strip posteriorly or 6th strip anteriorly, okay? And therefore it gives you this feel, feeling that there is some basal infiltrate. As a matter of fact, it's just a difference in inspiratory effort, okay? Now another difference in, you're supposed to have, that of different blackness post lungs. Okay, now you can see that the rule here is broken. This is more black than this one, right? And this is simply a pneumothorax. You can just see the edge of the lungs here. This is a pneumothorax. Okay, right? So different translucencies, right pneumothorax. And again, different translucencies, left pneumothorax. You can see that the lungs here has collapsed to the hilum on the left side, right? The whole lung is actually hyperinflated. You can see, um, so it is a pneumothorax on the left side, okay? And if you look here, you can again, spot that this is a bit whiter than this one, okay? And the reason is different translucencies because of left-sided oligemia set due to pulmonary embolism, okay, or Westermarck sign, sometimes it's called. Now let's go to another set of rules for the trachea, okay. Now the trachea is supposed to be midline, but maybe slightly deviated to the right. The angle of the carina should be less than 90 degrees. The right paratracheal edge, right, the edge of the right paratrachea should be less than 3 millimeters in an erect film, right? And the density should be similar to that of the aortic arch, right? So it shouldn't be greater than the density of the aortic knob. Now let's look at this. Now you can see here that the trachea is deviated to the left. Now it's deviated to the left is either pushed or pulled. Now it could be pushed by a large pleural effusion or a tension pneumothorax, or it could be pulled because of a collapsed lung, okay, on the left side, or collapsed lobe on the left side. So you can see that this trachea the rule is broken and it's now shifted to the left side. Now this is a smoker with hemoptysis, right? Now if you look on the lateral film, you can see a white shadow there, right, a white line there. So what's happening here is actually, and it's anterior, so it looks like this is a collapsed left upper lobe, right, and this is because of an obstructing tumor, okay, and this is, this is the transverse fissure, right, and actually pulled upwards, giving an S-shaped pattern, and this is right, typical of right upper lobe collapse with S pattern due to an obstructing malignancy, right? And if you look here, you can see that the trachea is going a bit more than 90 degrees, so it's playing with the trachea, right? Again, one of the rules has been broken. And you probably could see a double shadow on the double shadow on the right side of the heart, right? And there is bulging on the posterior aspect of the heart in here, right? Most likely because of the right atrium, right, is enlarged. Okay, so and you can see also that there is a bulge here and what's called the mitralization of the right side of the left side of the heart. And this is typical of obviously the double shadow of mitral stenosis, which is playing of the carina, the pulmonary artery dilatation, right, and this is actually the pulmonary artery dilatation and the mitralization of the left heart border. Okay. Now, if you look here, this is a central line, but you can see it's further away from the track here, suggesting that there is a mass here pushing the superior vena cava a bit away from that area, from its normal anatomical position, and this is a right paratracheal mass. So the broken rule is that the 3 millimeter, you know, uh, right tracheal shadow here is actually more. So widening of the right paratracheal space in keeping with the soft tissue in the middle mediastinum, right? So, and this is probably lymphadenopathy, right paratracheal lymphadenopathy. Okay, let's go to some more rules regarding the aorta. Now, the aortic arch or aortic knob is above the left hilum, right? So, if you see the aortic notch on the other side, then obviously there is the dextrocardia. Now you can see here that the the aortic arch actually is on the left side. Now this is a patient with chronic compound sputum, and you could possibly some ring shadows on the bases, right? And there is the heart apex is actually onto the right side, so this is dextrocardia. And so obviously the history is suggestive of carotid mass syndrome, okay, with dextrocardia. Now let's go to more rules, right? The cardiothoracic ratio. The heart diameter should be half or less than half of the chest diameter in an PA film with a good inspiratory effort. And the right heart border is formed by the right atrium. So if you end up with any right middle lobe pathology, then or specifically the medial lobe of the right middle lobe, because the middle lobe of the right on the right middle lobe has two parts, the middle and the medial segment and the lateral segment, right? So the medial segment is the consolidation that will obscure the right heart, the right heart border. Okay, so these are important rules to be aware of, right? And the left heart border is formed by the left ventricle. So if you have a lingular process, it will be obscured, right? If you look at a lateral X-ray as you're going down, you should be more black, decrease in density from the superior to the inferior in the posterior mediastinum, and the retrospinal spaces should be of the same density as the retrocardiac airspace. Now let's look here. Now this is just a typical X-ray of a broken rule of a cardiothoracic ratio of less than 0.5. And obviously, if you can see here, these are engorged highly. They are not concave, so they are really engorged, and most likely these are engorged vessels. And there is some cephalization or upper lobe venous diversion, and possibly blunting of the of the costophrenic angle there. And these are actually curly B lines. So the picture is a classic pulmonary edema. Okay, so this patient has pulmonary edema, and you can see almost the start of a butterfly on a pattern on the right side here. Okay, so several rules have been broken. The cardiothoracic ratio, right? The highly that are actually, now engorged and convex. The costophrenic angle is no longer sharp and deep. Okay, so all of these are actually suggestive of pulmonary edema. Okay, right. There is another interesting finding here is called peribronchial cuffing, which is again a sign of edema of the bronchial walls, right? And so it looks like part of pulmonary edema picture, and the upper lobe or cephalization or upper lobe venous diversion, right? Now, the rule that's broken here is that the right middle lobe or the silhouette sign here is gone, and therefore, and you have this triangular opacity there, right? and this is a smoker with fever and rigors, so the diagnosis is actually right middle lobe consolidation, and you can see it also in a lateral X-ray, and this is the right middle lobe consolidation on a lateral X-ray film. Right now, because of the smaller volume, there is consolidation here, but also some loss, some collapse. So there might be an obstructing lesion or sputum or secretions causing collapse. Okay. Now the left heart border, the rule that's broken is that the silhouette sign on the left side of the heart is gone. All right, so you cannot see a crisp, clear interface between the gas and the lungs and the solid organs. So the silhouette sign is lost in here, right, and suggestive of a lingular pathology. Okay, and you can see it in a lateral film. There's a um, lingular segment, um, actually consolidation. Okay. Okay. Now the broken rule here is that you should be seeing something which is dark as you go down. If it's getting whiter as you go down, then there is an area more white than it should be, and so there is suggestive of a mass or consolidation on this area, possibly in the left lobe. Okay. Right. Let's go to some more rules and abnormalities governing the Hiley. Right. Now the left hilum should be approximately 2 centimeters higher, but not more than 2.5 than the right. The Hiley should be the same density. Not one of them should not be actually more dense than the other, and the Hiley should be concave outwards. So these are the important rules for the Hiley. Now you can see that they are now very dense, and they look lobulated. They lost their concavity, right? And this is a typical pattern for bilateral hilar lymphadenopathy. And you can see even the paratracheal space here is actually is now wider than 3 millimeters, suggesting paratracheal lymphadenopathy as well. Okay, right? Some rules for the diaphragm. The hemidiaphragm superior margins are crisp clear with no haziness or blunting. This is a silhouette sign. The right hemidiaphragm is higher but less than 3 centimeters. The cosophrenic angle should be sharp on both views, right? They should be sharp and deep, and the stomach bubble is under the left hemidiaphragm. So beware of situs inversus. Okay, now these are important rules, right, that you should actually be aware of. Now you can see here that the right hemidiaphragm is much higher than the left hemidiaphragm. Okay, and there is also blunting here. On our lateral film, you can see how high is the right hemidiaphragm. Okay, obviously you could have a diaphragmatic paralysis, and the diaphragm might be higher, right? But then the pathology here is actually a subpulmonic. It's called a subpulmonic plurifusion, which is looking like a right hemidiaphragm. So this is not the right hemidiaphragm. It's actually that's the hemidiaphragm. This is a subpulmonic diffusion. Okay, and there is also blunting of the cosophrenic angle. The lateral one and the posterior one there, and this is all from a plurifusion, right? This is also happened on the left side here. You can see the gastric air bubble. There is a space between them, between the gastric air bubble and the left hemidiaphragm, and again, this is a subpulmonic effusion on the left side, and you can see blunting on the posterior cosophrenic angle, and actually this is the meniscus sign, which I'll explain in a minute. Okay, right. So we have a space, and it's because of a subpulmonic left-sided perfusion. Okay, now these are broken rules. No is whiter, not sharp, not deep cosophrenic angle, and this is a curly B line, all going with pulmonary edema. Okay. Now, there's some important common signs that you'd be able to recognize, like the air bronchogram sign on a chest radiograph or a CT scan. Now, air bronchogram means there is fluid in the air spaces of alveoli, and then there is actually consolidation. Silhouette sign is, as I mentioned several times, is the interface between the air and the solid organs, and this should be crisp clear, right? No haziness, no, you can just put a pen and go all the way along that line, the silhouette sign. Okay, right? So if you have any pathology in the medial segment to the right middle lobe, the right heart border is obscured. If you have a lingular pathology, the left heart border is obscured, right? Right, and obviously lower lobe, if you have any pathology in the lower lobes, it can obscure the the silhouette sign of the hemidiaphragm, as well as pleural effusions, which can also obscure the silhouette sign, loss of silhouette sign on the hemidiaphragm. Okay, the Western mark sign is a sign of pulmonary embolism or oligemia, right? Another signs, you can see are the hyperinflation, change in volume, right? This is a classic of consolidation. It's possible, it's likely to be, the left lower lobe, because the heart border is very clear, so it doesn't look like it's the upper lobe. And then you can see the air bronchogram, which is very clear on the CT as well. So there's air, air in the airways surrounded by consolidation. Okay, so air bronchogram. Now, this is a typical picture of a butterfly shadowing, and it's all about fluid in the airway, in the air spaces or alveoli, and this, if it's gross, it can also give an air bronchogram. So it's pulmonary edema due to butterfly batwing appearance of the X-ray, right? And so batwing, very high batwing appearance, alveolar edema, and as I said, it can even give you a feature of consolidation with an air bronchogram because there is so much fluid in the air spaces. Okay, now coming here, this is, you can see the silhouette sign is gone. You cannot see the left hemidiaphragm here, and this is called the meniscal sign. It's typical of perfusion. This is again a meniscal sign, and this is actually fluid in the fissure insisted here, and this gives you what's called a phantom tumor, because when you get rid of all this fluid, it disappears. It looks like a tumor or a mass, but as a matter of fact, it's just fluid in the transverse fissure, right? Silhouette sign is gone, meniscus sign, fluid in the fissure, right, and giving a feature of like a phantom tumor, right? Right, and this is an X-ray. You can see the vasculature here. You cannot see it here. So this is the Western mark sign of oligemia secondary to pulmonary embolism. Okay. Now, when you look at the hemidiaphragms, okay, you can look for diaphragmatic flattening, and by flattening means that this is actually less than 1.5 centimeter from the dome to the transverse line you draw this way. So it means that the diaphragms are flattened, and you can see these diaphragms are flattened, hyperinflated lungs, right, a barrel chest, and this is typical of obviously obstructive airway disease, right, like CMAN. Okay, we see wheezing and hyperinflation, flattened diaphragms, and increased retro sternal space and retrocardiac space because of parallel chest. Okay, now I'll just go through some miscellaneous patterns. Right now, this is typical of a lung abscess with a fluid level. There is more than multiple. These are another cavity there, right? And this is the fluid level. So this is lung abscess. Okay. This is what we call an interstitial pattern rather than an airspace pattern. Interstitial pattern means it's lines. You can just see lines. You don't respect the anatomy. Usually consolidation respects the anatomy. You don't respect the anatomy, and they are diffuse and usually bilateral. And these are interstitial patterns, so typical reticular pattern of interstitial lung disease, right? It's very important that interstitial patterns, the three types of interstitial patterns are known. These are called reticular patterns, the one I've just shown you, and then there is the nodular pattern and the reticulonodular pattern, right? So that unfortunately there are many diseases causing, for example, sarcoidosis causes all of the three, reticular, nodular, right? nodular, for example, you see it in reticulonodular, you see it, for example, in rheumatoid arthritis or nodular rheumatoid arthritis. And you can see also nodular infections like fungal and tuberculosis and fungal infections, right? So the differential of reticular interstitial patterns are of three types: reticular nodular, okay? And now you can see here, this is more of a nodular pattern. The small nodules, 2 millimeters, right? And this is typical 2 millimeters or less, and these are typical of miliary TB, right? So this is a nodular pattern due to miliary TB, okay? Now, the three varieties of pneumonia, the lobar pneumonia, you can see the consolidation here of the right upper lobe, right? The fissure has gone up a bit, so maybe there is a bit of lung volume loss here, right? And the typical thing is you see the air bronchogram. That's lobar pneumonia. Then you have the interstitial pneumonia, and the classic one, which we have seen so many times over the last few years, was the atypical pneumonias, classic of causing interstitial changes, like, for example, COVID pneumonia, right? And the classic thing is you see ground glass appearances on CTs, right? Usually bilateral, symmetrical, or asymmetrical. The bronchopneumonia is actually patchy and bilateral, right? And it doesn't necessarily respect lobar anatomical distribution, okay? And it's usually asymmetrical bronchopneumonia. So it's important to be aware of these three patterns, right? Lobar pneumonia, interstitial pneumonia, and bronchopneumonia. Okay. Now, this is a typical pattern. Somebody with fever, sweat loss for 2 months. You can see that definitely it's an upper lobe disease. It's patchy, some interstitial, as well as consolidation, and it's primarily it's looked like primarily upper lobe disease. This is the left half border is gone, suggesting that there is also lingular involvement in this. So it's bilateral upper lobe disease, patchy consolidation, some interstitial change as well, right? Possible some cavitation as well. So this is typical of pulmonary TB. Now these are the big masses, the lungs, variable sizes, typical of cannonball metastasis, right? An X-ray which is typical of cannonball metastasis. Okay, right? And another interesting X-ray, you can see it looks like it's gas behind the heart with the fluid level there. It's typical of a hiatus hernia. X-ray with a hiatus hernia, right? This is an X-ray. You can see there is abnormality. There are abnormalities in this area on the right side, right? But the interesting finding is that the ribs here, if you don't look at the bones, you might miss it, right? So the ribs are eaten. So this is suggestive of a pathology there. It's actually a metastasis, a rib metastasis, right? What I've tried to do is just take you through some of the tips and rules that govern chest X-ray, and if you are really aware of these, you'll be more confident in reading and interpreting chest X-rays. So there's so many videos on YouTube for mastering chest X-ray readings. As I mentioned, my talk is primarily just to give you a good start for becoming, an expert in reading and interpreting chest X-rays. So thank you much for watching, and all the best.